I'm delighted to welcome you to another My IVF Answers webinar this evening. I'm Barbara Scott. I'm chair of the Association of Reproductive Reflexologists, and I'm absolutely delighted to be hosting this event by Dr. Frühaufová from GYNEM Clinic, who are based in Prague. And Dr. Frühaufová is going to be speaking for us this evening on laparoscopy and hysteroscopy and whether they can improve your chances of conception. So we are absolutely delighted to have you with us. Thank you so much for being with us this evening.
Thank you too, Barbara.
I am just going to share the presentation, so just bear with.
Thank you. So I think that we are ready to start. So I will start with a presentation. It's quite a wide topic, so I hope to be able to cover the main points in the first couple of minutes. And of course, then you are free to ask any questions that you have on this very specific theme. So the question that I'm going to hopefully answer is that whether laparoscopy and hysteroscopy can improve the chances for conception. So brief introduction is that, let's say the infertility affects about 10 to 15% of the couples. Generally, we say that 1/3 of the infertility issues can be attributed to the women factor, 1/3 to male factor, and then we have the last third that is called the idiopathic or unexplained infertility. We do have some invasive diagnostic and therapeutic procedures that we can use in reproductive medicine. First one is the hysteroscopy, which basically means the evaluation or treatment of the uterine cavity issues. So hysteroscopy means inserting the camera inside the uterine cavity via the cervix, and laparoscopy basically being the same thing, but inserting the camera inside the abdominal cavity. So that allows us to visualize the small pelvis, to see the tubes, ovaries, to see if there's any pathology, such as, for example, in endometriosis or adhesion. So I'm going to go through it step by step later. So the question whether these procedures can actually improve the fertility outcomes, yes, they can, but only in selected patient cases. We have to strictly individualize the patients case by case, depending on their medical history, depending on the findings of the ultrasound, or sometimes we use the MRI as well. The role of, let's say, the routine laparoscopy and hysteroscopy prior to IVF still remains controversial. So when do we actually indicate the hysteroscopy? One of the main indication is in patients with the presence of intrauterine polyps or intercavitary fibroids. Both of them can be, or both of those pathologies can be quite clearly identified on a routine ultrasound. We know that the presence of both fibroids and polyp decreases the chances of successful implantation. So by removing the fibroids and polyp, we actually improve the chances for both spontaneous and IVF conception. These are quite easy procedures. Performing the operative hysteroscopy takes only up to 15 to 20 minutes. There is no long recovery time after the procedure, so the patient can actually get pregnant within the next menstrual cycle. There are some patients where we suspect that there might be some intrauterine adhesions. We might, again, identify them on a plain scan, or when we, for example, do the sonohysterography, we might actually see the adhesions. The patients prone to adhesions are the one who has had any inflammation going on inside the uterine cavity, or patients who had any invasive procedures such as curettage, or patients with repeated miscarriages. In those patients, we can, by performing the hysteroscopy, we can normalize the anatomic situation inside the cavity, and with that to improve chances for pregnancy. Also, sometimes we opt for the diagnostic hysteroscopy in patients with repeated implantation failure or in patients with repeated pregnancy losses. In those cases, we are looking for the signs of, for example, chronic inflammation or again, rule out the adhesions. We may even do the direct biopsy if we see any lesion and even do further evaluation of, let's say, the immune system situation inside the uterine cavity. So hysteroscopy can actually allows us to have further look at the endometrium and the cavity itself. When we move to the laparoscopy, so as I mentioned there, the laparoscopy may be diagnostic or surgical, more like details when there is some treatment needed. So the diagnostic laparoscopy is mainly to see whether the anatomical situation in the small pelvis is normal. We can perform the tubal patency test or coronal perturbation to make sure that the tubes are working well. We can see if there are any lesions of endometriosis or any adhesion present in the small pelvis. So let me just move on to the therapeutic laparoscopy option. So we have patients who have been diagnosed with or have suspicion of the mild or moderate endometriosis. We perform the laparoscopy basically depending on the symptoms of the patient. So we know that in endometriosis patients, the symptoms don't usually go hand in hand with the extent of the disease. So if you have patients with chronic pelvic pain, then this patient is most likely going to go through the laparoscopy prior any IVF. If you do have a symptomatic patient, then you would opt for the IVF first and then leave the laparoscopy as the last option. The same applies for the adhesions. So again, if we are suspecting the pelvic adhesions, we would indicate the laparoscopy in symptomatic patients, and in patients who are seeking the chances to conceive naturally or with the IUI to restore the normal anatomy and to help to add with the spontaneous or natural conception. The role of the adhesiolysis in patients prior IVF remains to be controversial. Only the patients who have severe adhesions of the ovaries and the ovaries are not accessible for the oocyte puncture, then those patients would actually benefit from having the laparoscopy first. In patients with endometriosis stage 3 and 4, again, depending on the symptoms, we always have to take into consideration the extent of the surgery, because those the surgeries tend to be quite long and demanding for both the surgeons and the recovery time. So we have to consider the cost and pros of the procedure. In most of the patients who don't have any severe symptoms, then IVF is actually preferred over laparoscopy. When it comes down to uterine fibroids, especially ones that are located inside the myometriums, the so-called intramural fibroids, the ones that are generally larger than 3 or 4 centimeters, and the fibers that tend to distort the uterine cavity. In those patients, we are usually opting for laparoscopy first prior to IVF. Also in patients with multiple fibers to restore the normal anatomy of the uterus. We have to keep in mind that there's some recovery time needed after both laparoscopic or open myomectomy, and this time is at least 6 months. So the patients has to have time to get the uterus healed properly, and there's still quite low, but there is a risk of uterine rupture post myomectomy. This risk is about 0.5 to 1%. Actually, the only clear indication to perform the therapeutic or operative laparoscopy is in patients with hydrosalpinx. We know that the presence of the fluid inside the tubes may actually deteriorate the chances for conception, and there is high risk of having the ectopic pregnancy. So in patients with clearly identified hydrosalpinx, we perform the laparoscopy and removal of the tubes prior to the IVF. So in general, we have to consider the pros and cons. So we know that hysteroscopy not that much, but laparoscopy is an invasive procedure, so there are some risks related to the procedure. So you have the risk related to anesthesia, also some possible complications like having that bowel or ureter injury when it comes to the extensive procedures. Also, there is some costs related in some countries. In some countries, of course, the insurance system covers the whole procedure, but it doesn't apply to all the European countries. You have to take into consideration the recovery time as well. And the diagnostic hysteroscopy and laparoscopy is definitely not the first line treatment in patients with unexplained infertility. So we know that in patients with clearly identified intrauterine pathology, such as the uterine fibroids or polyps, hysteroscopy will definitely improve the chances for pregnancy. When it comes to the laparoscopy, there are some selected benefits, as I mentioned, no doubt, in patients with the tubal disease and patients with fibers that are distorting the uterine cavity. Still, it's not clear whether patients with endometriosis prior to IVF would benefit from having laparoscopy if they are not symptomatic. So definitely hysteroscopy and laparoscopy is not part of the routine screening prior to IVF. So in the past, there were some steps that the patient had to go through before actually starting the IVF. So at the moment, there is no need to do the evaluation of both uterine cavity or the pelvic situation prior to IVF. So it is essential to say that we have to individualize the patients case by case based on the medical data that we have, based on the findings from the measuring methods, based on also their age. And we have to have a clear indication. We know that the procedures may be helpful, but we have to target the therapy, not use it as the routine screening. And on the other hand, for many couples, the IVF may actually bypass the need for the surgical intervention. So actually the IVF might come first prior to laparoscopy, for example. So thank you. And that's all for the brief introduction. I hope that you've heard everything since I was kicked out, but I hope that it came back.
So firstly, what I want to say is thank you so much. That was really interesting. And I actually could hear you all the way through. There was that little glitch in the middle, but I think you had to catch up with everything. So that was absolutely fine. So thank you. It was really informative.
Thank you.
The other thing I just want to say is to anyone who wants to ask questions, this is completely anonymous. No one else can see your questions. So, if you are a bit unsure about that and have been holding back, please do ask your questions in the chat box and I will read them out and we will go through them for you one by one, and hopefully that will be really helpful. And the other thing which I actually did want to mention before we began and didn't is that the European Fertility Society have launched a patient-centered care certification program, which really is it's a certification that allows you as a patient to identify that that particular clinic have engaged in a process that means that they are very focused on patient care. And I'm delighted to say that GYNEM are one of the first to have gone through that process and to be engaged in that whole process. So it means, you know, patient care is really at the top of their priorities. So we're very grateful to you for doing that, and I'm sure it's going to be reassuring for patients too.
Thank you.
So I am going to go. I'm just going to ask. We've got the first question here, which I'll just read out for you, and hopefully we'll gather some more information afterwards. So I have a uterine abnormality, but after many tests, including MRI, it is not clear what I have. Would a laparoscopy be a good method to have a look for real instead of an image to tell what I have?
Well, if the MRI can't give you the clear answers, then in that case, opting for both diagnostic hysteroscopy and laparoscopy might be a good idea, or asking for the second opinion during the second reading of the MRI, so by different radiologists. That you know, the problem with the MRI is that when you have a general radiologist, they might not actually be so skilled with the female pelvic anatomy. So if that's someone who is specialized in our organs, that might actually give you more clear answers without the need of having the invasive procedure. So I would start with this point first, asking your doctor for the second reading from someone who has more experience with the female pelvic anatomy.
Excellent. I'm sure that's really helpful. If there is anything else you want to add, please do put it in the chat box, and I will add into that. I have got a couple of questions myself that I think patients may want to ask. One of them is, if at what stage in their fertility journey would these tests become relevant? I mean, I understand it's completely individualized, but is there, you know, are there some guidelines that say, well, you've done this and you've tried that, and or you've been trying for so long, you know, X amount of time, maybe it would be sensible to undergo some of these investigations?
Well, there is no general answer to that, but overall, there's been lots of debates on this topic, even with the Fertility Society. But the diagnostic hysteroscopy is the tool that we use more often than the diagnostic laparoscopy, actually. And in general, we say that when the patient has three and more failures of a good quality, meaning euploid embryo, then it's time to start the further investigation to look inside the environment, both the immunological environment or the intrauterine environment. So then it's the time to start digging in and searching for the answers. But as I said, the hysteroscopy would most likely come first.
Yes, before any other investigation.
Yes.
Yeah.
And what I would also like to mention that we, especially at our clinic, and I think that most of the clinics are equipped with that, when it comes to purely diagnostic hysteroscopy, it may be done even without the anesthesia. So we have very thin instruments that might be inserted through the cervix. You can use some numbing gel that might be put inside the cervix as well. So if the patient hasn't had any surgery on the cervix, most of them can go through the diagnostic laparoscopy without the need of the anesthesia. And still, at the same time, you can, for example, do the biopsy.
That sounds like a really good place to begin, really. That's going to provide some information, and then you will gain some data, some information in terms of what would be the next step. So would there be an argument then for a hysteroscopy to be carried out, you know, before any further fertility treatment or interventions?
There is no clear data saying that all the patients should undergo hysteroscopy first, because the chances of conception with the IVF, especially with the cumulative chance of having, let's say, 80% likelihood of getting pregnant over 3 embryo transfers, then most of the patients wouldn't actually need any intervention in the first place. But
And
again, you have to be skilled with ultrasound. You have to ask the patient about their medical history, especially we are focusing on any inflammation processes, any but I said in any interventions in the past that would indicate that they might be some pathology present inside the uterine cavity. So you have to listen to the patient and
yeah, of course. So the other thing I was thinking about is that, I mean, clearly a natural conception is preferable to any intervention. So if during these procedures and investigations there are issues that are identified, would it, would there be a period of time? My guess is it's age dependent and ovarian reserve dependent, but would there be a period of time when you would say actually the healing process is completed, go and try to conceive naturally for XYZ?
yes, again, it's about the preferences, and as you well mentioned, it's the age factor that we have to take into consideration. So we know that up to the age of 35, we do have, let's say, the time for delay, and we can allow the patient, the couple, unless there is a male factor included as well, because we cannot leave the male out of it completely.
Yeah.
So if we have good semen quality, then in younger patients, we can allow them 6 to 12 months, depending on their preferences for the normal conception. It's especially patients with endometriosis who has had the laparoscopic surgery. And again, we have to inform the patients if the symptoms come back to come visit us earlier than we have agreed on initially. So to keep an eye on them if they do have any symptoms, because the endometriosis may actually come back quite quickly.
Yeah. Yes. Yeah. Absolutely. We have another question for those who have undergone hysteroscopy and D&C due to polyps. How long do you recommend waiting to start trying to conceive again, or to do IVF?
Well, I think I mentioned in the presentation that you can actually go ahead in the next cycle, because there is no need for any recovery, especially when you're sure that the polyp is not longer present. Then it's one of the issues that may actually come back because it is hormonally dependent. So the sooner you start, the better. And the same
Is there,
applies.
sorry,
I just wanted to mention that the same applies for the fibroid resection with the hysteroscopy. If it's done within one setting, sometimes the patients have to come again, because if you do have fibroid that are located partially inside the myometrium, they may actually come out later. So sometimes you do have to do the second look hysteroscopy and remove the remains of the fibroids.
okay. So it, from what you're saying, it means that actually they could go straight into IVF.
Exactly. And that's what we advise them to do, basically.
Okay, to take advantage of any window before there is any redevelopment.
Yeah.
Oh, yeah. Let me just check that we don't have any other questions. So one of the questions I was going to ask as a result of that, my curiosity, is there with these interventions and with removing things like polyps and endometriosis, is there a risk of scar tissue that may then cause further issues, or is that something that is contemplated in the original surgery?
Well, there is different situation inside the uterine cavity inside the small pelvis. So when you're actually removing polyps or fibers from the uterine cavity, the risk of adhesion formation is almost none. There might be a risk related to, for example, doing the adhesiolysis when there are some adhesions present, so they may actually come back again. So you may actually get some scar tissue formation later on. So sometimes you have to do repeated interventions. When it comes to the laparoscopy, it all depends on the extent of the surgery. So we know that patients, when we are removing the fibroids, when we have to put a suture on the uterus, then of course there's a risk of the adhesion formation. But long time ago, we've done a study on that, and we know that in patients who have underwent laparoscopy, the risk is quite low, and those adhesions actually tend to be quite mild, so they don't need any further intervention later on. But yes, endometriosis or fibroid surgery may be related to adhesion formation in the future.
Yeah. Yeah. The other question I was going to ask, which I know I've been asked myself. So my understanding is that really, in terms of endometriosis, the gold standard for diagnosis and also for treatment is laparoscopy. But I wondered if if there was some, high definition scanning that might identify, which it might identify it without that level of intervention, and if so, how accurate would that actually be?
Well, depending on who is actually doing the scan. So if you have a skilled, trained sonographer, those should be able to identify even small lesions of peritoneal endometriosis, but that really requires a lot of training. So um, we can define some lesions of the deep infiltrating endometriosis. So the endometriosis is actually affecting the parts of behind the uterus and the vagina, and there might be some bowel lesions, the bigger ones visible on the routine scan, but depends mainly on the machine that you have and the skills of the sonographer. So if you have a good machine and skilled sonographer, then you can tell quite a lot and you don't have to go through any invasive procedure. And I would say that the MRI, as we had in the first question,
Yes.
should be able to answer those questions and should be able to identify, because there are different ways how to do the images with the MRI, and there are some specialized ones that are focusing on the endometriosis, so they should be able to identify even small lesions.
And again, that's much less invasive than
Exactly,
going through.
exactly. And you don't have with the MRI, it's not like having the X-ray, so you don't have any risk related to that.
Yes. And my guess as well is it's actually having access to that kind of technology uh, as well.
I think that at the moment the MRI scans are quite widely accessible to most of the patient, but as I mentioned, there is a limitation to the ones, the physicians that are actually doing the reading. But since unlike the ultrasound, the MRI images are stable. So if you do have the data, you can actually quite easily do the second reading without having to do the go through the MRI again.
Of course.
Yeah.
Yeah, that's great. Thank you so much. We have another question. I had fluid in my cavity before frozen embryo transfer, and they did a hysterectomy. Why does it happen? Basically, my hysteroscopy was fine,
Mm-hmm.
and I just can't quite read this. So they did
Dilatation.
dilatation, and how can I imagine this treatment? How long does that last? Or yeah.
Okay, okay. Well, that's something that we see in quite a small percentage of patients, especially the ones that are being prepared for the frozen transfer with the estrogens therapy. So sometimes it's more likely to be a mucus that is growing inside the cavity that actually there might be two ways how to explain. Either it's coming from the tubes in patients with Hydrosalpinx, for example. So when there is a fluid present, it might actually evacuate itself inside the cavity, or it is a mucus that is being produced inside the cervix, and it's due to high estrogen levels. So if there was no finding on the hysteroscopy with the dilatation, the fluid should come out of the cervix. As I said, you have to make sure that the tubes are fine and there is no fluid coming out from the tubes. In that case, you can proceed on with the treatments. I did have patients who had this kind of issue repeatedly on the estrogen. So what we sometimes do is we evacuate the fluid shortly prior the embryo transfer, let's say 2 days before that, we take the fluid out, and then we, if the ultrasound finding is normal, then we go on with the transfer. Sometimes it even resorbs itself once you start the progesterone.
Okay, that's really helpful. I hope that's answered your question. I think that's a really comprehensive, interesting answer. I mean, it must be a concern, and Hydrosalpinx particularly. Yes, you're saying thank you. Is of course a real worry, and there must be a concern that that's what's causing the problem. I think that's what most patients would be worried about. So actually, understanding that that process can be undertaken, and then the frozen embryo transfer can continue on afterwards is very reassuring.
Well, actually, there's something that we call the functional Hydrosalpinx, that it's a special clinical unit that the Hydrosalpinx just comes and goes. I mean, sometimes it is visible on the scan, and it's mainly depending on the hormonal production. So in most of the patients, you see it by the time of the ovulation, mostly in the scan. And this is the Hydrosalpinx that is partially communicating with both the cavity and the abdominal cavity and the uterine cavity. So the issue is when the fluid is coming out inside the uterine cavity, and that it may actually flush out the embryo that you place in. So in that case, it's better to remove, even though that it's coming and going.
Yes,
basically.
Yeah. It's just, I guess it's just not worth taking the risk that might be a possibility.
Yes,
so
and the patients are always at a high risk of having ectopic pregnancy, which is something that we want to avoid as well.
Of course, absolutely, of course. Okay, I think we have answered all the questions we have in this evening, but I think on your last slide you had some contact details.
Yes.
So I am hoping that there will be people who will be watching the recording, and I'm hoping if they need to make contact with you, they can.
Sure.
Contact details on that slide, because I'm sure there will be others that will want to experience the benefit of your expertise in this area. So if anyone does have questions, please do contact Dr. Frühaufová on the contact details that are on the last slide. There is an email address there.
Of course, I'll be happy to answer any questions that will come later. I will send you an email with my reply. So don't hesitate if you do have any questions later on.
Thank you. We've got a few thank yous coming in, so it was really interesting.
Thank you too.
Well, thank you for coming and joining with us. It's such an important topic, and I know that there are lots of people who will watch this on on playback, who will find it really important and useful information as part of their fertility journey, because I think the points that you made were very clear and very succinct, and but also you can see how it needs to be individualized. You need to understand your own personal circumstances, and of course that's where where you come in. So a huge thank you for sharing that with us this evening. And a thank you for being with us on behalf of the European Fertility Society, for sharing your knowledge and experience this evening.
Okay, it was my pleasure. So nice evening to all of you, and we'll be joining soon again with a different topic.
Wonderful. Thank you so much. And
Thank
thank you
you.
for everyone who's joined us this evening.
Thank you. Bye-bye.
Bye now.